We would like to welcome you to the 2025 Symposium on Substance Use Research. This panel will be a discussion on novel uses for GLP agonists and neuropeptide-directed therapies to treat substance use disorder. So a few reminders before we begin. This session is being recorded, and we will send an email to registrants and post on social media when the recording is available. Also, this session is a webinar, so attendees will be muted. Please use the question and answer function to submit questions, and we will try to answer them as time allows. So just as a brief introduction, my name's Dan Morgan. So I am a chair and professor at Idaho State University, previously an associate professor at Marshall University. So in that respect, I also represent the West Virginia NBRE, which is one of our sponsors in this meeting. So from this point, I'm excited to introduce today's speakers. We have 4 experts joining us across a range of disciplines: Dr. Sue Grigson, Dr. Aya Osman, Dr. Rodrigo Espana, and Dr. Stuart Clark. So let's take a moment to do brief introductions of our panelists, and we'll start with Dr. Grigson. So could you describe your background, research areas, and experience relevant to this panel?
Sure. Thank you, Dan. Hello, everyone. Yes, I'm Sue Grigson. I'm a professor and chair of neuroscience and experimental therapeutics at the Penn State College of Medicine. And I've been studying addiction for a number of years, preclinically first, and more recently in the last 5 years, translational research involving clinical trials with humans. And about 2019, started to test whether GLP-1 agonists could be used in order to treat opioid use disorder. So that's been my focus. And that was preclinical. And then we were able to get a grant to study it both preclinically and in the clinic. So I'll talk about some of that today. Thank you.
Great. Thanks, Sue. Dr. Osman, if you could introduce yourself.
Good morning, everyone. My name is Aya Osman. I am an assistant professor at University at Albany, SUNY. My research background started with development of the endogenous opioid system and how it can be affected by the developing gut microbiome and how that affects opioid-related behaviors. In particular, I was looking at depression for my PhD. Since then, I've delved deeper into the gut-brain axes and mechanisms by which the gut microbiome affects the brain. And in recent years, I've started looking at regulation of the endogenous opioid system by ketamine and whether ketamine engages the endogenous opioid system to elicit its antidepressant effects and the therapeutic potential of ketamine during prolonged abstinence in opioid use disorder, currently in preclinical models, heroin self-administration rat models, and then moving from ketamine to looking at ketamine's metabolites and other structurally similar compounds that have less of ketamine's negative side effects as potential therapeutics for opioid use disorder.
All right, great. Thanks, Dr. Osman. Dr. Espana, if you could introduce yourself.
Sure. Hi, everyone. I'm Rodrigo Espana. I'm professor and interim chair in neurobiology and anatomy at Drexel University. I've been working on the hypocretin orexin peptide system since about 1999. As a graduate student, I worked on it in the focus on arousal and how hypocretins affect sleep-wake function, and then shifted to how the hypocretins regulate motivation for cocaine and now other drugs of abuse. And I've circled back to my origins, and now I'm looking at the interface between hypocretin regulation of substance abuse and sleep and how those two interface. We do a lot of measurements of dopamine neurotransmission in brain tissue, in whole animal preparations, and now I've started exploring how hypocretin neurons themselves alter their activity across behaviors related to motivation for drugs.
All right, great. Thanks, Dr. Espana. And Dr. Clark, if you could introduce yourself.
Hi, everyone. I'm Stuart Clark. I'm associate professor at University at Buffalo in pharmacology toxicology. I did my PhD with Olivier Chiavelli, who was in the business of deorphanizing neuropeptide GPCRs. I worked on 2 neuropeptide systems as a graduate student, and I've been continuing that work and characterizing the systems and looking for a variety of different therapeutic potentials for them. And I've been partnering with Research Triangle Institute, and we have a robust drug discovery program for the neuropeptide S system.
All right, great. Thanks, Dr. Clark. All right, so I'd like to thank all of our panelists for joining us today. I think we can go ahead and get started with our discussion, and we'll start with some of the pre-prepared questions that we have. Attendees, if you have questions, go ahead and ask those, and we'll either answer them at the end or we'll fit them in if we can do that and it fits with sort of the flow of what we're covering. So let's start with a question which is what are the most urgent public health policy implications for this research field? And any of the panelists, or we could start with Sue, for example, if you'd like to start.
Yeah, sure. I think from my perspective is just getting exceedingly clear in terms of the safety of the GLP-1 agonist for the treatment of substance use disorders, and being able to then move this to being able to move through the FDA so that we can have something available. I think every day it is urgent because every day we are losing people in this country due to substance use disorders. And we are losing about right now 80 or so thousand people a year right now to opioid use disorder. Now over that to alcohol use disorder, and 3 or 4 times that to nicotine. And so I think, yeah, every day is urgent. And so really we need a lot more money funneled into this just so we can move faster. I think the safety is the issue so far. The GLP-1 agonists are looking very promising. They're very promising preclinically. And so far, the data coming through clinical trials also are very promising. But with everything else, one medication is going to work for one person, and it isn't going to work for another. And so we need to learn a lot. And even though these drugs have been approved since 2005 for the treatment of type 2 diabetes, for example, there's still a lot of work to be done and being done on the formulations in order to have a better safety profile. So I'll leave it at that so others can add in.
Great, thanks, Sue. Do our other panelists have things they'd like to say on this topic?
Well, I just want to sort of go on with what Sue was saying, that new targets. I know I've had discussions with people inside NIDA, and they internally look for new targets in the literature, and it seems that they have in their minds a way to sort of fast track these, but I don't know how well formalized these fast tracks are, like having an in-house NIH pathway that, they find a target, they reach out to the investigator. If they have, nascent medchem done, can these targets immediately be tested in-house without, going through the granting process, just to get that sort of proof of concept first? I think that would be super valuable. I know in-house, like I said, we've had those discussions, but I don't know how formalized they are.
Mm-hmm.
Yeah, I guess I can weigh in with ketamine and the safety concerns surrounding that. Of course, we know ketamine has its own abuse liability, and so the public hearing that ketamine might be used as a, or being considered as a potential treatment for opioid use disorders can come across paradoxical because of its own abuse liability. So I think more consideration needs to be given, at least for looking at ketamine and its neuropeptide effects, looking at the dose that we're studying for ketamine, looking at the dosing regimen that we're considering here, 1 dose versus 2 dose, how often patients would need to be dosed for the therapeutic effects to be elicited. And then the mechanism of action needs to be given close consideration here, where at specific doses, ketamine might be acting as a direct agonist versus at other doses, it might be a allosteric modulator, which might be a slightly safer way to target opioid receptors and target them in opioid use disorder. So I think there's a lot of safety concerns there around using drugs that have their own abuse liability in the treatment of addiction.
And I'll just add one quick thing, which is that there are several clinical trials that have been completed or recruiting now for hypocretin receptor 1 or 2 antagonists. These are orexin 1 and 2 antagonists. And these are for opioid use disorder, most of the ones that I remember right now. And based on preclinical work, they seem like they might work. And so there are currently dual receptor antagonists for sleep, for insomnia. So they're sleep producing. And so, again, this is where it comes into play about what the interface is between regulating sleep and how sleep can be disturbed with substance abuse and to what degree that actually ameliorates craving. So I'm heartened to know that that's ongoing.
All right.
Yes, and if I could just say, Dan, sorry, that in terms of new targets, the GLP-1 agonists have their major side effect is, of course, the GI distress, and that's where combinations with perhaps neuropeptide S or ketamine or and certainly the orexin 1 or 2 antagonists are something to consider. We've combined the GLP-1 preclinically with an orexin antagonist, and they were at least additive, if not synergistic. I think more synergistic, and so that would allow for the possibility of using lower doses of the GLP-1 agonist, perhaps having less of an impact on the GI negative those negative consequences, and then being able to have even perhaps better efficacy in terms of treating the substance use disorder. So that work needs to be done.
Great. So do we have any other comments on the question for our panelist before we move on to the next question? Okay, so I think we'll move on to the next question. So the next question is, so what are the current limitations surrounding the assessment for potential therapeutic utility or abuse liability for the neuropeptide drugs that each of you are working on?
For me, it's medchem, right? It's always trying to find, like, I have a great collaborator, Research Triangle Institute, but I know others who are working in the field, getting the interest and the funding in, because as I said at the beginning, I started with orphan systems. And so when we de-orphanize a system and we want to interrogate it, we want, those small molecules, antagonists, agonists. But when we go to chemists, they always want to know what it does. And we don't know what it does because it's an orphan system, but it's a new target. And so there's a huge gap there for us. There's a lot of work we need to do using the peptides, which are not ideal, right? To show some kind of proof of concept before we even get medchem interest. And so, I've been working on neuropeptide S since 2004. And it's just now over 20 years that we have viable molecules, right? And so for me, that's a huge gap, starting with an orphan system.
Great, thanks, Stu. Do our other panelists want to weigh in?
I think for me currently, working with the racemic mixture of ketamine versus stereoisomers, the R and S. The studies characterizing the stereoisomers are, even in preclinical models in terms of abuse liability, antidepressant effects, and so on, are lacking. And so this is something we're focusing on here in terms of looking at the isomers and then looking at the metabolites of the isomers and their safety profiles, and then going further with those as opposed to the racemic mixture of ketamine. So more studies on the stereoisomers, their interactions with the opioid receptors, cryo-EM level would be very helpful.
One other thing that I'd like to comment on is, and this sounds like I'm being critical. I'm not. I just want to provide both sides of it. So the interest in understanding mechanisms and circuits and cell types and the move from all of us to have those expectations of specificity are getting in the way of the profound importance of chemistry, right, and pharmacology, and just testing drugs and their behavioral consequences. When you submit a grant, you have to have a bunch of the mechanism. You have to have a bunch of the cell type specificity these days. And so you could put out a really fantastic proposal that should be funded, that if it were conducted, you would get a lot of answers about the behavior and the pharmacology, but people maybe just don't get that excited about it. And I think that that's a huge limitation. And, I blame myself too. I'm not immune to that. So I think that's something that somehow we have to change.
Yeah, one thing that's is really important is just talking to our program officers and trying to figure out what mechanisms are most conducive to being able to get a little more directly to those problems and not being so having the strict requirements of some of the final cellular molecular pieces. And with the one grant that we had to start to look at GLP-1 receptor agonists preclinically and clinically, they actually wouldn't allow us to look at the brain. And that's like, well, the offhand shocking, but they wanted us to try to streamline this in order to try to determine as quickly as we could, which GLP-1 agonists might work best and under what conditions. And there's still so much more work to be done in terms of the different profiles of the different GLP-1 agonists, but also the impact of the different regimens. So when the GLP-1 agonist is, if it's administered at higher doses and with short time frames, we can get tolerance where the drug's not effective in reducing in the animal models, the fentanyl seeking, for example. So we need to understand that, and then we need to know how to space it out. So again, we come back to, needing certainly a lot of funding in order to be able to address these questions, behaviorally and then mechanistically, because we do know that those mechanistic findings at the cellular and molecular and genetic levels, that's what we need. We need that information for tomorrow.
Great. So before we move on to the next question, panelists, do you have anything more on this question before we move on? Okay, so we'll go ahead and move on. And I'll just encourage attendees, if you have questions, I don't see any yet, but if you have them, to go ahead and put those into the chat, and I'll pose them to the panel to answer. So I think the next question, sort of going back to maybe sort of a more broad question, would be, so what do you see as the most critical knowledge gaps on this topic? So, and panelists, what are your thoughts on knowledge gaps that exist?
Yeah, if you don't mind, I'll start here. So one of the discoveries that we've had, and Dr. Clark and I have talked about this extensively, is that we're seeing long-lasting effects of peptide antagonists. And I'll give you a very specific example, and maybe Dr. Clark can give another. So we work with hypocretin receptor 1 and 2 antagonists. These are the orexin 1 and 2 antagonists. And orexin 1 antagonists, if you give them acutely, they will have reductions in active self-administration and also reductions in reinstatement behavior. And so they're essentially reducing drug seeking. We've seen this for opioids. We've seen this for cocaine, which is most of the work that we've done. But if you treat animals and then wait 24 hours, you still see changes in behavior. We also identified that this acute pharmacological onboard effect that people have reported numerous times over the years are associated with reductions in dopamine responses to opioids and to cocaine. And it turns out if you treat an animal with one of these antagonists and you wait 24 hours and then you measure dopamine neurotransmission, you also see this disruption in dopamine neurotransmission. And we set up a set of experiments where we have these animals, they self-administer cocaine in this case. They do it in a very specific way. I'm happy to give details if you're interested. And then we do a seeking test on the first day of abstinence. And so animals will press levers. They don't get cocaine, but we get a measure of their seeking behavior. And then over the course of 7 days, 14 days, 28 days, we do just one other seeking test, either at 7, 14, or 28 days. And when we do the seeking test, what you see is what's referred to as incubation of cocaine craving or cocaine seeking, where they press more on the second seeking test than they did on the abstinence day 1 seeking test. And if we treat rats with hypocretin receptor 1 antagonist right after the first seeking test on abstinence day 1, for 7 and 14 days, now we have data, they will reduce their pressing 7 days, 14 days later. This from just one injection 7 days or 14 days earlier. So we're changing something about the system. We also know that this is associated with normalization of what would otherwise be aberrant dopamine neurotransmission. And so we've shifted the system. We've normalized dopamine neurotransmission and its long-lasting effect that has a behavioral consequence. So I think this is a major gap in knowledge, because so much of the work that we've done, including my lab and when I was a graduate student and so on, is that you're looking at the onboard pharmacological effects. That's pharmacology. That's how it works, right? But we're seeing that these pharmacological interventions have long-lasting effects. What are those changes? I don't have the answer to that, but I think that's.
So and also, Rod, go ahead, Stuart.
I was just going to follow on. So we don't know when the peptides in most cases are released. And so what Dr. Espana is talking about, he's putting on an antagonist, right? Which supposedly is blocking the actions of orexin in that moment, unless for some reason that molecule you're testing is actually an inverse agonist in those particular neurons, right? Which is also another question, right? And you have to get at that. And so I think in the near future, we're going to have the ability with these sort of neuropeptide grab type sensors. And we can now go in, because it's been very difficult traditionally to know when these peptides are released and where they're released and why they're released, right? And so we've been relying on antagonists, saying, oh, we put the antagonists on board, now they don't do that. So we surmise or deduce that the neuropeptide must have been released then. But we don't have that information. It's a complete black box for many of the neuropeptide systems, right? In the resolution, if it is there in the literature, it's 10, 20, half-hour time intervals. And so I think that's a huge gap that plays on what Dr. Espana is talking about.
And I would just ask Dr. Espana one little question, and that is, for that protective effect, does the orexin antagonist need to be on board by itself, or is it the fact that it's been on board in the presence of the new seeking behavior in that first exposure during the extinction? Do you know? Do you need the behavior plus the orexin antagonist, or the orexin antagonist alone?
That's a beautiful question. So it's more effective when you have the behavior and the antagonist.
Yeah, so there's some plasticity going on. Yeah, it's really
and
interesting.
We've seen that hypocretin neurons are active to lever presses, not to inactive lever presses. So I think we are recruiting those neurons to fire and be engaged. But if you just take a naive rat and you inject it with one of these antagonists, and then you measure dopamine transmission, it's slower uptake and reduced release. So I think it has also, and it is long lasting. So we've seen that in a naive animal for at least 20. I think it's both things, but I love your question.
It's really interesting hearing this, because this is exactly what brought us back to the opioid system with ketamine, in that we know one acute exposure to ketamine has these long-lasting antidepressant effects. And so this paper's not out yet. It will be hopefully by archive by next week or the week after, but we did some simple studies where we injected rats with three different doses of ketamine, and then looked at the endogenous opioid system at the molecular level 1 day after, 3 days, and 14 days. 7 days after. We didn't get as far as 14. And we see changes in opioid receptor levels at the protein level using ELISA up to 7 days after this acute injection. We just got some really cool data with radioimmunoassays showing that endogenous opioid peptides are also increased 7 days after this acute exposure. As you mentioned, where and when this peptide release is happening, we don't know, but we do see that it seems to persist. Now, on a behavioral level, when we took rats and we got them to self-administer heroin for 2 weeks, and then they underwent a forced abstinent period in their home cages for 2 weeks, and we give ketamine infusions towards the end of that 2-week abstinence, and then assess drug-seeking behavior, we didn't really see an effect straight away of the ketamine infusion. When we did see an effect of the ketamine infusion is when we then primed those rats with a heroin injection, and then we saw a reduction in levopresis. So your point about the plasticity and that there's has to be maybe something ongoing in the environment for ketamine's effects to kick in is also interesting, because we're seeing that at the behavioral level, but not necessarily at the molecular level that you need to prime with heroin or something to see the long-lasting effects of ketamine. So just wanted to share that in case it sheds any light on the questions you were asking.
So the long-lasting effects, I think, are so promising, because that is what you want in a way, changes that are positive, that don't require continued treatment. So that's very promising. We have the complexity of different substrates mediating different kinds of relapse that is elicited by cues or context versus drug, prime versus stress. So that's another way that we need to challenge all of these potential interventions, and you all do, to try to see how well they will or won't be effective. For orexin, the antagonist, the GLP-1 agonist currently is not as effective at reducing cue-induced seeking. It does it nicely, but not thoroughly. With drug and stress-induced seeking, it's quite thorough. But the orexin antagonist is really, really does a uniquely, great job at reducing cue-induced seeking. So when the two are together, that makes it even stronger. One of the gaps we have, along with many others, but another one we have is, how and when can we stop the treatment? In this case, with the GLP-1 agonist, people wonder that all the time in terms of the regulation of body weight, for example, and with opioids. So, right now in the clinical trial that we're running, we'll have the individuals are on the GLP-1 agonist across 3 months using the Ozempic dosing for type 2 diabetes. And then in the last month, they're off. And so we're trying to take a look to see and understand how craving is and/or return to drug use in that month off period. So that's something else we need to know.
Great. So we do have our first question from the audience, which is related to sort of the topic that we're talking about right now. So I'll provide a little bit of context for the question. So the attendee works with a neuropeptide system that's similar to orexin in many ways. And unfortunately, the antagonists have not passed clinical trials yet. So the question is, does anyone have any suggestions for promoting research, grants, general public interest into these neuronal systems when we don't have approved treatments thus far?
So that's a good question. Yeah, and it's tough. The answer I'm going to give is actually I don't know how I feel about it, to be honest. But I'm worried that as soon as an orexin antagonist is found to be really useful and goes on the market for treating substance abuse, that there's going to be less interest in preclinical work in that arena, right? Maybe we don't need to know that much more about it is kind of what I worry about. So if your peptide system hasn't been approved it means that there's a ton of work to be done, right? So just forge ahead, keep going, ask all the preclinical work, ask all the clinical work, questions that you possibly can. And if I get a grant to review and it's interesting and powerful and has a vision, it doesn't matter if it hasn't been approved for treatment. That's my view, at least.
Mhm. That's a very positive and optimistic viewpoint, and I think it's really, accurate. There is so much work to do, and it's true if it's not yet approved that will be obvious. But so I think that's great. And the other is to make sure, and maybe this is already clear, but that you are talking to your clinical colleagues as much as possible, because even if you're not going to start a clinical trial, their input may help to shape your preclinical work, which will help you to understand the, questions that they're having in the clinic, and you may be able to address those questions. And you may not know that this is their big problem unless you get to talk with them.
So I'm going to give a slightly different perspective. So I don't know the reasons why it's not approved. If it's a clinical trial failure, if it's a clinical trial failure, that's a larger mountain to get over. But if it is a clinical trial failure, I would really scrutinize why it failed. I've heard many stories from other systems that the people who were running their clinical trials actually recruited the wrong population. And so you need, I would be, if I were going to write the grant, I'd be very upfront. This was found, it was failed, but it was these population, not these other populations. And I would address that up front in the grant application and say, but if we were focusing on this other population, would work. The other thing is something that other people have already touched on. Maybe in a clinical trial, it wasn't dosed correctly or in the right context or in the right way. And then you can focus your grant on really teasing that out and bringing to light those questions. So I guess what I'm trying to say is take that failure and find the questions that failure brings to light so that you can go and address those as part of your research program. I don't know what Sue has to say on that. I know she has more experience in that.
No, I'm really pleased that you brought that up, because I don't think we maybe understood enough from the context of the question to know. But yep, I agree with you. Some studies will look negative, but when you take a good look at it, you realize, or folks who were engaged in it tell you that, the timing was wrong, that, by then this particular formulation would have worn off. All kinds of things happen. So yeah, it's very good to explore those details.
And another thing to also look at, I think, Dan, we're going to get to that. So I know for our system, we have a huge biological sex issue with how the system works. And so if the data is available, if they make it available and they didn't use that as one of their variables, you can maybe get the data and tease that out and data mine that and really come, as I said, get those questions that the clinical trial brought up. Instead of seeing it as a negative, you look at it as an opportunity.
One other avenue a lot of folks are taking, and I think is very useful, is their, as making use of large Trinetics database and other databases. And this has been a way, it's not a double-blind placebo-controlled clinical trial, but it is one that it is an assessment that allows you to get information about what's happening in the clinical population, human population, and that can help. If you need that information, it might help to substantiate your preclinical, grant proposal, and or it might help to substantiate a clinical trial.
All right, great. Thanks, panelists. So we do have another question from the audience. So I think Stu's point's good. So we do have a pre-prepared question on sex differences that I think we should cover as part of the panel. We do have another question from the audience, which is so also pertaining to these persistent effects. So could the panelists discuss how they maintain translational relevance using these models, especially with regard to reinforcement schedules, reinstatement acquisition models?
I can go. So I mentioned that we exposed our rats in a very specific way to cocaine for the long-lasting effects study that I talked about. And so what we did there is we used the intermittent access schedule reinforcement. So this is something that was developed by David Roberts at Wake Forest when I was there as a postdoc. And it took me a little while to embrace it, but I was there in the trenches when he was developing it. And what I really like about it, even though you can't ask a rat to behave and take cocaine like humans take it in little binge chunks, you can force the pattern on them, right? So that maybe the neuro chemical responses or consequences of taking drug in that way can be mimicked. And so what we do in that case is rats get exposed to 5 minutes access to cocaine, and they can take as much as they want. There's no intertrial interval. And so they can load up, and they learn to take a lot of cocaine during that 5 minutes. And then for the subsequent 25 minutes, the levers retract and they don't have access to the cocaine. And so they have to, what they end up doing is they take a lot of cocaine, you get spiking cocaine levels in blood and brain, and then you also get spiking dopamine responses because of that. And then it peters off and then it repeats. We do it 12 times over a 6-hour session. And so in that model, I think that we're trying to replicate a little bit more of the exposure patterns that humans get. And then secondarily, in terms of the reinstatement portion, we don't do extinction. I think it's a great model in many ways. We can ask lots of things with extinction and then reinstatement models. But in this case, what we're doing is just these seeking tests. So they're an extinction test, but it's just a single one, so to speak. And it attempts to model, and then abstinence. Yeah, that's the key part. So then we have this one seeking test, abstinence, and then another seeking test. And what we're trying to model there is either somebody was incarcerated or went into rehabilitation and is not exposed anymore to drug. And by treating on the first day of abstinence, what we're trying to do is to curtail craving early in abstinence when it's pretty high and avoid it from growing over time. And if dopamine changes are a metric or a consequence or a comorbid change with craving, if they track each other, then we know that we're getting the dopamine therapeutic effect early on and that it's lasting. And so that's how we're trying to be translational. The goal would be if somebody is incarcerated or if somebody chooses to go or is forced to go to rehabilitation, that early on we would be able to treat them with these agents and reduce their craving.
Yeah, I think similarly here, I have a big interest in clinical or translationally relevant work, which is why I wanted to collaborate with Dr. Yasmin Hurd and use the heroin self-administration paradigm in rats, as opposed to the condition place preference or something that I'm more trained in mice, where it's the experimenter giving the drug of abuse to the animal. So for our studies, we used heroin self-administration, and then again, we wanted to look at how ketamine would be given in the clinical population, which would hopefully be the patient going into a center to receive the ketamine infusions as they currently do for depression. And so we tried to mimic that in that the rats were given ketamine infusions in a different context to where they were taking the heroin. We also tried to give the ketamine as an infusion at a similar dose that humans would get, which is 0.5 milligrams per kilogram. We did some calculations to see what the equivalent would be in rats and gave that as an infusion as opposed to an IP injection, again, to try and get it as close as possible to how it would be given in the clinic. And based on our data that we didn't see any effects on Q-induced heroin seeking, but we saw effects on after heroin primed drug seeking. It indicates that maybe this could be a potential therapeutic for patients who relapse or are briefly re-exposed to their drug of abuse, and ketamine has these sort of protective effects against that. So definitely trying to keep in mind the clinical population we're treating here and mimic it as closely as possible in our experimental design.
So I'm not going to talk about what we do. I'm going to talk about what I would like to have money to do. So there's an older paper, I think people have read it, where have rats self-administer, they have a history of taking cocaine, and then after a number of weeks, they give them free choice between food and cocaine. And I believe it's as high as 80% of the rats choose food. And so I would love to have the resources and money to do a study where we only study that 20% that's left. But we do not have the grants or resources to put that many animal subjects through and then take out that 20% to do a study. And in my mind, if I ever get to the IND stage with any of our programs, that's what I want money to do. I want to really look at that 20% because my gut tells me that that's where some of the translational failure comes, because we are looking at metrics from rats who, given the choice, may not take cocaine, and we don't study that 20%. I don't know what other panelists' feelings are on that.
I think that that's a very good point. The individual differences are critical. You know, we don't ever throw out animals, so to speak. I mean, we separate them into the prone and the resilient or resistant. And I think that that does help us to make sure that at least if we can protect them, we know we can protect those that are most vulnerable. But yeah, we need a lot of money in order to be able to understand what mediates the vulnerability in the individuals that are vulnerable. And I think that protection is those who are protected, they are as important to know about. Why are they protected? How are they protected? Also, there are a lot of behavioral studies that need to be done more fully. You know, sorry. Exercise is very protective. Enrichment is tremendously protective. You know, the alternative suite, or, you know, that is a kind of an enrichment as well. And the more we would understand that, the better. So yeah, when we have our animals singly caged, this is not the normal situation. And so, yeah, it's funny how we've gotten so far in terms of what we can do experimentally with, you know, cellular molecular level. But still, we really do need resources to back up to some other, you know, so we could take a look at other issues that are very fundamental in terms of what else makes for this vulnerability.
All right, great. Thanks, panelists. So we do have another question from the audience, which is remarkably similar to one of our pre-prepared questions. So this pertains partially to like clinical research design. So again, I'll read a little bit of context before the question. So this is from an attendee that works with a social service agency that is working on developing randomized controlled trials to evaluate women's prison reentry program, which is providing access for GLP-1 effects on addiction. So the goal of the trial is to test the impact of this access and other services on life history outcomes like recidivism and not necessarily clinical outcomes. The question is, do you have any advice based on your clinical research for treating addiction with GLP-1 agonists?
Well, yes, I would say so far. You know, just in terms of our experience, so it kind of pertains also to the previous question in a sense that, you know, being able to ask the questions preclinically and clinically at the same time is so valuable, whether it's, you know, one lab or multiple labs or across the country. But, you know, one thing we learned from the preclinical data is that that less seemed to be more. The lower doses are very effective in reducing opioid craving. They've also been shown in the Hendershot lab to be effective in reducing, you know, drinking in his alcohol studies. And so I think that's one key point, that less may be more. The lower doses aren't effective in treating type 2 diabetes or in treating obesity. So this is different for these motivated behaviors. The other thing is when we looked at the data, the drug was actually effective on the very first day. And so that's really important in a clinical setting because you want to know, are your patients going to be protected immediately, or are they going to be at continued, risk? And so I think that's a key point. I think it depends also on the substance that the individual, is it alcohol, is it opioids? If it's opioids, you can have the added protection of buprenorphine and methadone. And, so far, that's the way we've run the studies. When we tested at the Caron Treatment Center, some folks were on buprenorphine and some weren't. So we did have the opportunity to look at the GLP-1 all by itself, and it was effective. So those are the main things that I can think of off the top of my head. And the other is considering, how or if the GLP-1 agonist treatment would need to be stopped. And, maybe people couldn't afford to have it longer. That's going to be an issue. So that's going to need to be tracked. They may need to be tapered. And, in the way that Dr. Espana was kind of hinting at, new treatments, the interventions along with the GLP-1 agonist may be helpful, so that if the GLP-1 agonist has to be discontinued, they would have learned some new strategies and new habits.
So I guess, sorry, just a question for you, and if you're not comfortable sharing this, but are you looking at repeated dosing with the GLP agonist, or just the one dose? And are you seeing differences between how long the effects last from one dose versus several?
So in the clinical trial, only at repeat dosing. So it's, chronic study, and we haven't yet been able to look at it acutely. I would like to look at it acutely, but we haven't been able to do that yet. In the animal models, we have done both. So acutely, the GLP-1 agonists work beautifully. Chronically, they work very nicely, but we have found that if we titrate the dose up, so we would titrate it up every 3 days, for example, and this is another effort to try to model what is going to happen in the human condition. So, we try, but what we found is that if we titrate up to a dose that acutely is effective, that dose may not be effective at all. So big tolerance. So we've had to titrate to lower doses. We also may need to space it out. Elizabeth Yerlag has a paper with dulaglutide in an animal model, drinking alcohol. They were administered the dulaglutide once a week, and it was protective across, 4 weeks or so of testing. So, it may be that spacing it out works better. So we're actually working on that now with semaglutide to see how that may work better for us.
Okay, so I think we do have a question on sex differences that Stu had sort of alluded to. We have about 10 minutes left, so I think this is an important topic that we should probably cover as part of the panel. So really the question is, so what examples of important sex difference exist regarding the use of different neuropeptide-based drugs that you're working on?
I guess I can start. So we published recently, we're gathering more evidence, but we have at least some evidence that from the agonist side for the neuropeptide S system, that the stage of estrus is important. So at certain stages of estrus, we see the same effects in females that we would see in males, but at other stages we don't. And why did we ask this? It's more of a long-term thinking, and I think that this comes back to the clinical trials and how you design your clinical trials. If we didn't ask this question in the animals and we went into a clinical trial, the clinical trial would fail, right? Because if we didn't ask the participants, half of them, which would be female, I would assume, not to track that part of their biology, we would just say it doesn't work, right? And so, and we're seeing this in more and more as we look at it. We have actually a poster tomorrow at our local neuroscience research day where we had done our neuropeptide S receptor antagonist work in cocaine, Q-induced reinstatement, and it worked great in both females and males. It maybe even worked better in females, and there was no estrus for the antagonist side. What I talked about before was agonist. Now we've moved to oxycodone, and it doesn't seem to work in females in certain paradigms. And we don't know why. And of course, estrus is very short in rodents. And so we did track it, but we don't have enough, because when you do, as Dr. Espana was talking about, when you do that relapse test, you get one shot at the end. Like you can't retest. So we were just crossing our fingers that maybe half of them would be in certain phases and half of them the other. But no, it was 90-10%. And so we have to have much larger cohorts. And that's the other thing that's really problematic. So the first study I talked about, where we found that estrus cycle interaction with our system, my poor student, she had to run in parallel 90 animals. And in that 90 animal study, we could only do one dose, because 45 were going to be in the control and 45 were going to be in the dose, because within that 45, only 1/3 would be in a certain phase and the other 2/3. So to get an N of 12 to 15, we needed to run 45 per group if we're doing freely cycling. And then a lot of people are like, why don't you just overectomize and then give estrogen in that? And my response to that is, that's a huge assumption that estrogen is the culprit, because ovaries do much more than estrogen.
Mhm. We basically found something, very similar, so that as I said, the GLP-1 agonist works great to reduce Q drug and stress-induced seeking. In males, we tested it in females. Had we not tracked the estrus cycle, we would have said that the GLP-1 agonist would look to be less effective in the female. But what we found is that the seeking was very high during estrus compared to the other 3 phases of the cycle. And the GLP-1 agonist then reduced seeking during that time. So what we would have had is a floor effect, basically, in the other 3, phases of the cycle. So, we were lucky that we had evaluated that, so we didn't draw the wrong conclusion. That being said, I'll tell on myself to say that in this clinical trial, we are not asking women about their phase of cycle, and we should. So if we get to run another clinical trial, I'll make sure we ask.
So for my studies, we haven't yet started to look at sex differences. I just wanted to highlight that for ketamine, Zanos et al. 2016 paper, they did find differences in metabolites after ketamine in males versus females in the brain, where I believe it was the females, I'm not going to quote it in case, but there were differences in terms of ketamine's metabolites in plasma and the brain following ketamine. We also know from the literature that for the preclinical studies, it seems the sex of the experimenter administering the ketamine to the animals also plays a role in the antidepressant effects that you see in male mice versus female mice. This was published in Nature Neuroscience by Polymnia Giorgio, who's now at Milwaukee University. So things to consider here, even your experimental design, male versus female, who might be affecting how the animals are behaving, and maybe something to even consider for clinical studies, the clinics that these patients are going into and what's happening there. But this is all based on preclinical data for ketamine, that there might be some interesting sex differences going on there.
I didn't know that. That's
I'll add to that. So the study that we published, it was an all-female team. The whole study was an all-female team, which also brings in another complication. To recruit an all-female team to my lab to run this particular study is difficult.
Yeah, we've seen similar experimenter sex influencing things. We've seen with a predator odor stress exposure, preclinical PTSD model, that a couple of graduate students who were men got really great rates of susceptibility. So in our model, about 1/3 of the animals are susceptible to the predator odor stress and show this, variety of alterations, both neurochemically and behaviorally. And then the other 2/3 are resilient. They look almost identical to control animals. And when we've had women in the lab do these experiments, it's like 18%, maybe 15% are susceptible. And so, yeah, it's amazing. It's amazing stuff. It's another complication that I'd rather not deal with, but also fascinating.
Should have known about that.
So I think we have 5 minutes left. So the other thing that I'll add about the sex differences. So I think something that's maybe not totally appreciated, and we have noticed for cannabinoids, so obviously that's not a neuropeptide, is the potential for these agonists also to impact like the female cycle. So we're thinking about this in terms of what are the effects occurring at different stages of the cycle, but I think there's also this possibility that treatment with some of these agonists can also impact the cycle itself. So that's something that's I think probably not totally appreciated in just the general study of sex differences. So we do have 5 minutes left. We do have another question from the audience that I think we can get to quickly before we have to let everybody go. So this is a question pertaining to the use of ketogenic diets with curbing craving and relieving withdrawal symptoms.
Yeah, it's a fantastic question. I'm admittedly not versed in this, but I can tell you the only thing I can share is that there's a graduate student in the lab right now that keeps asking me to do this experiment. She is a lifter, so she lifts weights and she's very strong. And she's really interested in how diet impacts life in general. And this is something that she's been pressing me to do. And because you've asked this question, I'm getting closer and closer to saying yes to this.
This kind of links back to the lab that I did my postdoc in, Dr. Drew Corali, who's now at Wake Forest. We were looking at the effects of the microbiome on addictive-like behaviors in mice and rats. And it seems changes to the gut microbiome, whether induced by the ketogenic diet or other diets, I was looking at polyphenols and other interventions and antibiotic treatment, it does change sensitivity to some of these drugs, where we see in mice at least that depletion of the gut microbiome makes the animals slightly more sensitive to the drugs they're taking, so they end up taking less in the long term. So I wonder if that's potentially how other dietary modifications are eliciting their effects via changes to the microbiome and sensitivity to some of these drugs, and how the behavioral effects of the sensitivity to them.
Okay, great. Did other panelists want to weigh in before we close? Okay. All right, so I just wanted to finish up by saying thank you to all the panelists, all the attendees that have participated